Hello, and thanks for joining me for this fourth video in our series on migraine. In case you are just joining me, I'm Christina Lindemann. I'm a PA specializing in neurology at UC San Diego Health. So far, we have discussed the impact of migraine on our patients, the phases of a migraine attack, symptoms that might tip us off to a possible migraine diagnosis, and tools to diagnose and categorize migraine. In this video, I'm going to discuss treatment options, goals, and how to measure success. I'll also share a few tips on improving outcomes. In regards to migraine treatment, we think of two main pillars. One pillar is acute treatment, or a treatment used to stop individual migraine attacks. The other pillar is preventive treatment, or treatment used to keep migraine attacks at bay. How do we decide when a patient with migraine needs treatment? Well, the American Headache Society provided guidance on this in their 2021 Consensus Statement Update. In regards to acute treatment, the AHS recommends acute treatment for any patient with a confirmed diagnosis of migraine. Preventive treatment, on the other hand, should be used for patients whose attacks significantly interfere with daily routines despite acute treatment, who have intolerance or contraindications to acute treatments, or who have found acute treatments to be ineffective, or who have had overuse of acute treatments. They should also be considered in patients with frequent attacks, typically characterized by 4 or more days per month, or 2 to 3 days per month with notable disability. So let's get to it and talk about acute treatment options. The AHS has also given us goals to keep in mind with acute migraine treatment. These goals include rapid and consistent freedom from pain and associated symptoms without recurrence, restored ability to function, minimal need for repeat dosing or rescue medications, optimal self-care and reduced use of healthcare resources, minimal adverse events, and cost considerations. Consistent with what I see in practice, they also note that suboptimal acute treatment is often associated with higher disability associated with migraine and a higher risk of disease progression. We aren't going to get into the details of acute medications, but there are several classes to consider, including triptans, ergotamine derivatives, gepants, NSAIDs, and combination analgesics. The AHS also recommends considering neuromodulation devices, which are non-invasive wearable devices that have been FDA cleared for migraine treatment. In consideration of acute treatments and which one to utilize, migraine-specific agents are best for individuals who experience moderate to severe attacks, while mild to moderate attacks can be treated with non-specific medications such as NSAIDs and acetaminophen, unless the patient does not respond. Patients will respond differently to each treatment, so we may need to try more than one before we find the right fit. We should also consider non-oral formulations of acute medications, such as nasal sprays or injectables, for patients who are prone to significant nausea or vomiting with their migraine attacks. I also review medical comorbidities that may indicate contraindications to certain treatments. For example, I avoid triptans and ergot derivatives in patients with a history of stroke or heart attack due to their vasoconstrictive properties. Regardless of which medication we choose with our patients, it's important to coach them to treat early for best efficacy and to prevent progression in their symptoms. We've even had evidence for treatment with certain agents, such as certain gepants, in the prodromal phase of migraine. Medication is just one part of a comprehensive treatment plan. Optimizing nutrition, physical activity, hydration, sleep, and mental health can be impactful for our patients as well. Now let's talk about preventive treatments. AHS also provides goals regarding this. These goals include reducing attack frequency, severity, duration, and disability, improving function, improving health-related quality of life, optimizing self-care and enhancing a sense of personal control, reducing psychological symptoms and stress, and reducing overall treatment cost. Ideally, preventive medications can also improve responsiveness to and avoid escalation in use of acute treatment and reduce reliance on unwanted, poorly tolerated, or ineffective acute treatment. Preventive medications for both chronic and episodic migraine include CGRP inhibitors, such as the monoclonal antibodies and gepants, anti-seizure medications, antihypertensives, such as beta blockers, and antidepressants, such as tricyclic antidepressants. Additionally, onabotulinum toxin A is FDA approved for use in chronic migraine only. In their 2024 update, AHS noted that CGRP targeting migraine therapies are a first-line option for prevention. Non-pharmacological approaches play an important role in prevention too. We can consider non-invasive neuromodulation, nutraceuticals, biobehavioral therapies, and lifestyle modifications. As with the acute medications, not every patient will respond to every medication. It's also important to allow enough time for an adequate trial before assuming a medication is not working and switching. We can monitor response to preventive medication by using validated questionnaires, including, but not limited to, HIT6 and MIDAS for functional assessments. These functional assessments are often given at baseline and during treatment, particularly if an objective tool is needed to show improvement. The mTOQ-5 can also be utilized to assess responsiveness to acute medications. The more we can help patients to recognize their migraine symptoms and support them in treatment of them with shared decision-making, the more impact we will have on their quality of life. We as PAs really have the opportunity to meet our patients with compassionate care to help them recognize, prevent, and treat their migraine attacks. Thanks for joining me in this video series.